When people think of psychiatry, they often imagine medications, diagnoses, and maybe even padded rooms. But if you ask most psychiatrists what defines our work, where it all truly begins, they'll tell you it starts with the interview. The psychiatric interview is more than just a set of questions. It's a conversation with purpose, a delicate, powerful blend of science, observation, and deep human empathy. In this video, we'll explore what makes the psychiatric interview so special, what it is, how it's structured, why it's so different from other medical encounters, the role of empathy and how it reveals the invisible wounds people carry. Whether you're a student, clinician, or someone simply curious about mental health, let's take a look inside the sacred space of the psychiatric interview. What is the psychiatric interview? The psychiatric interview is a clinical conversation where the psychiatrist gathers critical information to understand the patient's mental state, explore their life story, assess for psychiatric diagnoses, and most importantly, to form a human connection. It's part medical evaluation, part narrative inquiry, part emotional bridge. You're not just taking a history, you're stepping into someone's world. And in psychiatry, words are the main diagnostic tool. The goals of the psychiatric interview. Let's break it down. The interview serves to establish rapport and trust, gather information about symptoms, stresses, and functioning, perform a mental status examination, assess risk, including for suicide, violence, or self-neglect, formulate a diagnosis and working hypothesis, create a treatment plan in collaboration with the patient. But behind these clinical tasks lies a deeper mission: to make the patient feel seen, heard, and understood, often for the first time. The structure, organized, yet flexible. While every interview is different, most psychiatric interviews follow a semi-structured format. Here's a typical roadmap. 1. Introduction and consent. Start with presence and clarity. Hi, I'm Dr. Naim, a psychiatrist. I'd like to talk with you today to understand what's been going on and how I might help. Ask for consent. Is that okay with you? Can we talk here comfortably? Even small courtesies set the tone for collaboration. 2. Chief complaint. Let the patient speak in their own words. What brings you in today? How have things been lately? Don't interrupt too early. Their first 2 minutes might reveal everything. 3. History of present illness, HPI. Explore the symptoms deeply. When did it start? What was the trigger? How has it affected daily life? Any recent changes in sleep, appetite, concentration, mood, or behavior? This is where patterns emerge and where empathy starts to bloom. 4. Past psychiatric history. Ask about previous diagnoses, hospitalizations, suicide attempts, or self-harm, past treatments, medications, therapy. What helped and what didn't? This gives context and builds on what they've already been through. 5. Medical and substance use. History. Psychiatric symptoms often overlap with medical conditions or substance use. Ask any medical issues, current meds or supplements, alcohol, cannabis, or other drugs. Have you noticed any connections between use and your mood or sleep? 6. Family psychiatric history. Mental illness often runs in families. Ask about mood disorders, schizophrenia, suicide, hospitalizations, substance use. This helps you understand risk and also reduce shame. You're not alone in this. 7. Social history. This is where the patient's life story unfolds. Explore childhood, school, and education, jobs and finances, relationships, living situation, legal issues, strengths, hobbies, spiritual beliefs. This isn't just small talk, it's the soil their suffering grew from. 8. Mental status examination, MSE. The MSE is a psychiatrist's version of a physical exam, but for the mind. It covers appearance and behavior, speech, rate, tone, coherence, mood and affect, thought process and content, including delusions or obsessions, perception, hallucinations, cognition, orientation, memory, concentration, insight and judgment. Most of this is observed organically during the conversation. 9. Risk assessment, This part is vital. Are you having thoughts of hurting yourself? Have you thought about suicide or made a plan? Any thoughts of hurting others? Ask clearly, calmly, and without shame. Suicidality is a symptom, not a moral failing. 10. Formulation and plan. Once you've gathered the story, you summarize. From what you've shared, it sounds like you've been experiencing symptoms of depression, especially after the recent loss. I think therapy and possibly medication might help. What are your thoughts? Involve the patient. Invite their input. Respect their pace. This is shared decision-making, not a prescription from on high. The science, clinical precision. While the interview feels like a conversation, it's also a highly skilled assessment. You're always watching for red flags for psychosis, mania, suicidal risk, clues for specific diagnoses, inconsistencies between reported symptoms and observed behavior, functional impact on work, relationships, self-care, language use, memory, abstraction, subtle cognitive cues. You're using diagnostic criteria, but you're also building a narrative formulation, the why behind the what. It's clinical, but it's also deeply human. The art, what can't be taught by books. Here's what they don't teach you in textbooks: how to sit in silence without flinching, how to sense when someone's holding back, how to notice a tear forming when they say, "I'm fine," how to gently steer without taking control, how to honor their defense mechanisms, even when they frustrate you. This is the art of psychiatry. It takes time, humility, and countless interviews to refine, but it's also what makes the work so meaningful. The empathy, the healing begins here. Sometimes, the psychiatric interview is the first time someone has said their truth out loud. First time admitting they hear voices, first time talking about trauma, first time crying in front of someone without being told to toughen up. You, the interviewer, are witnessing a sacred moment, and in many cases, being witnessed is the beginning of healing. That's the power of empathy. Not fixing, not labeling, just being present, curious, and kind. Common pitfalls and how to avoid them. Let's cover a few traps clinicians can fall into and how to sidestep them. Rushing the interview. Even in time-limited settings, take 30 seconds to truly connect. It pays off. Focusing too much on checklists, use structure but follow the story. Talking more than listening. Remember, your silence creates space for their truth. Avoiding hard questions, like suicide. Ask clearly and gently. You won't plant the idea. You might save a life. Forgetting strengths. Ask, what's helped you cope? What are you proud of? Resilience matters. The psychiatric interview is a craft. It's not just a data gathering session, it's a living, breathing, dynamic encounter between two people, one of whom is trying to find meaning in their pain. It's part detective work, part soul work. Yes, there's a DSM checklist. Yes, there are algorithms and scales. But at its heart, the psychiatric interview is a structured way to say, I see you, I hear you, and I want to understand what it's like to be you. And sometimes, that's the most therapeutic moment of all. Final thoughts. The psychiatric interview is the foundation of everything we do. Diagnosis, treatment, healing. It's science, yes. It's also presence, story, and empathy. In a world filled with screens, alerts, and automation, psychiatry still begins with one human sitting across from another, saying, "Tell me your story." That's where healing begins. That's where psychiatry begins. If this video deepened your appreciation for the psychiatric interview, give it a like, share it with fellow clinicians or students, and subscribe for more content like this. Drop a comment. What have you learned from the interviews you've done or the ones you've experienced? Until next time, take care of your mind and take time to truly listen to someone else's.